Good morning, Jinnah Sindh medical students. Thank you for tuning in to today's lecture. My name is Dr. Atiya Dhala, and I'm an associate professor at Houston Methodist Hospital and at Weill Cornell Medicine. I'm a pulmonary and critical care physician, and I'm also the medical director of the virtual ICU here at Methodist. Today, I will be speaking about the basics of mechanical ventilation and will share some tips on ventilator management of COVID-19 patients. The roadmap for today's talk is we'll be going over the types of respiratory failure. Then we'll talk about what is a ventilator, what is mechanical breathing, and then we'll take a deep dive into the ventilator modes. And finally, in the last 10 minutes, we'll talk about some ventilator strategies for COVID-19 patients. So what is natural lung ventilation? Lateral lung ventilation is the way we breathe. It is called negative pressure breathing. It starts off with inspiration and downward movement of the diaphragm, causing alveolar pressure to drop below the airway opening pressure. This allows air to be sucked into the lungs. With inspiratory flow over time, the lungs are inflated and alveolar pressure increases. Finally, inspiration stops when alveolar pressure and airway opening pressure become equal. This is an active process and expends about 3 to 5% of total body energy. This work can increase tremendously in patients with asthma and ARDS. Then, when expiration begins with relaxation of the diaphragm, the elastic recoil of the lungs and the chest wall brings the lungs back to their resting position, which is called functional residual capacity, or FRC. This is passive and doesn't consume any energy. Artificial lung ventilation or mechanical ventilation is the opposite of the way we breathe. This is termed intermittent positive pressure ventilation. Here, when artificial inspiration starts, the ventilator system raises the airway opening pressure from the baseline to the peak pressure, generating a temporary gradient where the opening pressure is higher than the alveolar pressure. As the gas is pushed into the lungs, with inspiratory flow over time, the lungs are inflated and alveolar pressure rises exponentially. At the end of inspiration, both airway opening pressure and alveolar pressure are equal at peak pressure level. The inspiratory flow stops. When artificial expiration begins, the ventilator lowers suddenly the alveolar opening pressure from peak pressure to the pressure baseline, generating a gradient where airway opening pressure is lower than alveolar pressure. The elastic recoil force of the lung chest wall pushes gas outside the lungs. At the end of expiration, the alveolar pressure and airway opening pressure are equal to the pressure baseline. The expiratory flow stops. Similar to natural expiration, it is passive and consumes no energy. What are the types of respiratory failure? Type 1 respiratory failure is called hypoxemic respiratory failure, or a failure to oxygenate. Now, hypoxemic respiratory failure has been classically defined as an arterial PaO2 of less than 60 millimeters of mercury. The threshold of 60 millimeters of mercury is somewhat arbitrary and reflects the shape of the oxygen hemoglobin dissociation curve. Now, when your PaO2 is 60, your O2 sat is 90, and anything above that, you are in the flat portion of the oxygen hemoglobin dissociation curve. But when the PaO2 falls below 60, then the saturation of hemoglobin with oxygen falls precipitously in most people. There are 5 pathophysiological mechanisms in the classification of hypoxemia. 1 is ventilation perfusion mismatch. 2 is shunt. 3 is decreased inspired O2. 4 is hypoventilation. And 5 is impaired diffusion. Whereas hypoxemia from VQ mismatch is responsive to supplemental oxygen, hypoxemia from shunt is not. In a hospital setting, a decreased inspired O2 or PiO2 can usually be excluded because most patients will be placed on supplemental oxygen. Hypoventilation can also be rapidly excluded if the patient is not hypercapnic by performing an arterial blood gas. Impaired diffusion by itself is not an important cause of acute hypoxemia, in that oxygen transfer across the alveolar capillary membrane to the red cells is usually perfusion limited and not diffusion limited. So in summary, most patients in the intensive care unit with acute hypoxemic respiratory failure have some combination of VQ mismatch and shunt. Now we're going to go over the causes of acute arterial hypoxemia based on their primary pathology. So if the pathology is in the air spaces, then the hypoxemic respiratory failure could be from pulmonary edema or ARDS, or pulmonary hemorrhage, pneumonia. If the problem is in the interstitium, it's probably related to pulmonary fibrosis or extrinsic allergic alveolitis or viral pneumonia. If the pleural space is involved, then hypoxemia could be from a pneumothorax or a pleural effusion. If the airways are involved, it could be from asthma, COPD, or mucus plugging. And if the heart and pulmonary vasculature are involved, it could be from a pulmonary embolism or an intracardiac or intrapulmonary shunt, to just name a few. Now, type 2 respiratory failure is the failure to ventilate. Here, this is manifested by hypercapnia and respiratory acidosis. Now, carbon dioxide tension in arterial blood is a function of two very important variables, alveolar ventilation being one of them, and CO2 production being the other. So PaCO2 is directly proportional to CO2 production and inversely proportional to alveolar ventilation. So when alveolar ventilation is decreased, PaCO2 is increased. Now, what are the factors potentially decreasing alveolar ventilation? They could be disorders of the central nervous system as it relates to drugs depressing the CNS, or hypothyroidism, metabolic alkalosis, structural lesions in the central nervous system, or idiopathic alveolar hypoventilation. Or it could be problems related to the chest wall and neuromuscular system, such as kyphoscoliosis, myasthenia gravis, Guillain-Barré syndrome, polymyositis, etc. Or problems related to the lungs and airways like COPD, left ventricular failure, severe ARDS, and severe asthma. So the first thing that might happen is, so let's say you have a respiratory center that's depressed by a drug, so there's a reduced drive, and the reduced drive leads to reduced ventilatory effort, leading to ventilatory failure. Or you may have an impaired neuromuscular function or an excessive ventilatory demand on the respiratory system, leading to inadequate ventilatory output despite increased effort, leading to ventilatory failure. Now I'm going to go over some of the key physical elements. First, let's talk about pressure. What is pressure? Pressure is the force against resistance applied uniformly over a unit area of surface. What is pressure gradient? It is the difference between pressures in area A and area B. Let's say these areas were connected by a tube, then the pressure gradient drives gas from an area of higher pressure to an area of lower pressure. The gas movement is called flow. What is gas volume? Volume is a measure of the space occupied by a quantity of gas at a given pressure. Tidal volume and minute volume are examples of gas volume. What is gas flow? Gas flow refers to movement of gas volume over time. Inspiratory flow is the flow towards the patient and it has a positive value. And expiratory flow is the flow away from the patient and it has a negative value. Resistance. Resistance is defined as the force that tends to oppose or retard gas movement. Resistance depends on three factors. One, it is flow dependent, so the higher the flow, the greater the resistance. Two, it depends on the physical properties of the tube, such as the length and the internal diameter of the tube. And three, the physical properties of the gas, for example, including density and viscosity. Now, this last key element is something I want you to pay extra attention to, and that is compliance. And I'm comparing here the balloon and the human lung because they have one thing in common. They're both elastic, hollow, and are gas-tight structures. Their volumes change at different levels of internal pressure. Now, compliance is a measure to express the pressure-volume relationship of such structures. So let's say we take two balloons made of the same elastic material. The wall of one balloon, as you see in green, is slightly thicker than the one in yellow. Using a T-piece equipped with a valve, the two balloons are connected to a source of high-pressure gas. In this arrangement, the internal pressure remains the same. We gradually open up the valve, causing gas to flow into the two balloons, and internal pressure continues to increase. The balloons begin to expand. And not surprisingly, the balloon with a thin wall will expand faster than the balloon with a thick wall. If we measure the internal pressure and volume simultaneously and plot these readings, we will get two graphs. The two graphs have different angles. The smaller angle tells you that that is the more non-compliant lung, and the larger angle shows that that lung is definitely the more compliant lung, or balloon in this case. In principle, compliance is a static property and should be measured in conditions of zero flow. Now we're going to move on and talk about what is a ventilator and what is mechanical breathing. The therapeutic tool for mechanical ventilation is the ventilator system, which usually has 6 parts. One is the supply of gas, usually high pressure air and high pressure oxygen. 2, the supply of electrical power. 3, the ventilator itself. 4, a breathing circuit with all the necessary accessories. The airway, the artificial airway, in this case, the endotracheal tube, and the lungs of the ventilated patient. The ventilator, therefore, is just one of the parts that is required for ventilation. It can be compared to the wheel of a bicycle, let's say. If the wheel of the bicycle is not properly integrated into the system, it cannot do anything about riding the bike. So the ventilator alone can do nothing about mechanical ventilation. I'm going to now try to deconstruct the ventilator for you. And so let's start with the simplest model of a ventilator system. The primary function of the ventilator system is to generate positive airway pressure. How does it work? Let's begin with a simple balloon inflation system. If you see on top, you see that it has a full gas cylinder with a valve, a blue connecting tube, hand A, the balloon itself, a pink tube, and a hand B. Now below you look at it, the real ventilator system. So hand A is now replaced by the inspiratory valve, and hand B is replaced by the expiratory valve. On this side, the circuit pressure is equivalent to the airway opening pressure, and the balloon pressure is equivalent to the alveolar pressure. Balloon inflation occurs when the inspiratory valve opens and the expiratory valve closes. The circuit pressure becomes higher than the balloon pressure, and gas is pushed into the balloon. As a result, the balloon grows. Balloon deflation occurs when the inspiratory valve closes and the expiratory valve opens. The circuit pressure drops below the balloon pressure and gas is pushed out of the balloon. As a result, the balloon shrinks. Valve control in a real ventilator is more complicated than this, but the basic principle remains the same. Now, this balloon model is highly comparable to a real ventilator system. The cylinder in the model corresponds to the high pressure gas supply provided in the ventilator system as shown here. Actually, a ventilator system needs supply of two gases, high pressure oxygen and high pressure air. Now, the hand A in the model, as I mentioned before, corresponds to the inspiratory valve. The hand B in the model corresponds to the expiratory valve. The blue and pink tubes between the white piece and the two hands correspond to the breathing circuit. The balloon corresponds to the airway and the lungs of the ventilated patient. So what is a mechanical breath? A mechanical breath is a breath realized through a ventilator system. To carry out mechanical ventilation, these are the commands a ventilator must receive from the operator, such as when should inspiration start and stop, when should expiration start and stop, how the delivery of inspiratory gas can be controlled, how big is the mechanical breath should be, how high should the baseline pressure be. Each mechanical breath takes a certain length of time to complete. That is the breath cycle time, and it's composed of the inspiratory time and the expiratory time. That is TI and TE. Triggering refers to a point when inspiration starts. Cycling refers to the time when inspiration ends. So TI, or inspiratory time, is the duration from a triggering point to the following cycling point. And TE, or expiratory time, is the duration from the cycling point to the following triggering point. Breath cycle time is the duration from one triggering point to the next triggering point. Now we're going to talk about the ventilator modes and how to set up a ventilator. I'm going to first present to you a case that I saw recently in one of our COVID ICUs. She's a 55-year-old morbidly obese female, presented to the emergency department with 4 to 5 day history of cough, fever, and diarrhea. She was initially admitted to the acute care floor, but got transferred to the ICU due to her escalating needs for oxygen requirements. She went from 2 liters to 4 liters nasal cannula to 6 liters and then to 100% non-rebreather. She also was breathing very fast and had extreme respiratory distress. She got intubated, and as you can see here, she's intubated on arrival to the ICU. And her chest X-ray shows diffuse bilateral infiltrates consistent with ARDS. This was the findings on her chest CT. There were very few portions of her lungs that were not affected. And of course, an RT-PCR of her sputum confirmed COVID-19. So I wanted to go over how you would set up a ventilator, and then we'll go over how we do that in a COVID-19 patient. So first of all, you have to set up the tidal volume, then the respiratory rate, the FiO2, the PEEP, and then I to E ratio. Let's tackle one of these at a time. First, tidal volume. So let's take a 5 feet 6 inches tall male. This patient's actual body weight was 350 pounds. But if you were going to use that, then the patient will get giant tidal volumes. So therefore, the best way to calculate the tidal volume requirement is by looking at the ideal body weight. I have showed you the formula on the right side of the screen for ideal body weight formula. So in this particular patient, his ideal body weight is 141 pounds. Now we take that divided by 2.2 to give us the weight in kilograms, and then we calculate how much tidal volume to give this patient. So these are tables that are available. So in this patient, if he was 5 feet 6 inches tall, then if you want to ventilate him at 6 mLs per kilogram, you'll be giving him 370 mLs of tidal volume. For a woman of the same height, 5 feet 6 inches tall, you would give her 340 mLs of tidal volume or 6 cc per kilo. Now, to ventilate a normal patient, let's say there was a patient that was normal that went for surgery and developed post-op respiratory failure, then you would ventilate them with a tidal volume of 6 to 8 cc per kg ideal body weight. There is no reason in today's ventilator management to ever go above 8 cc per kg. Now, in this particular patient that I mentioned to you has ARDS, you would ventilate this patient at 4 to 6 cc per kg ideal body weight. If the patient had asthma or COPD, then you would give them also on the lower side of normal tidal volumes. Now that you've decided what tidal volume you want to give this patient and you've set up the ventilator, you now have to choose one of the modes of ventilation. Now, in the traditional modes, there are two main types. There's volume control and pressure control. And in them, you could either choose volume assist control or volume synchronized intermittent mandatory ventilation, or SIMV. In pressure control, you could choose pressure assist control, or you could use pressure SIMV. Now, it's outside the scope of this lecture today to talk about the advanced modes. Now, let's say you chose for this patient a volume mode. So volume continuous mandatory ventilation, CMV, or volume assist control. Now, just remember, different ventilators have different nomenclatures. If you are using a Hamilton ventilator, that is the only ventilator that calls this type of ventilation CMV, or continuous mandatory ventilation. Most other ventilators will call it assist control, or AC. Now, in this mode, the machine delivers the same tidal volume during every inspiration, whether it is initiated by the ventilator or by the patient. So let's say we set the tidal volume at 500 and a rate of 12. If the patient was completely passive, then the ventilator would give 500 cc tidal volume every 5 seconds. But if the patient was to breathe over the ventilator, then the ventilator would sense that the patient wants to take the breath and would give the full 500 cc tidal volume. So this occurs regardless of the mechanical load on the respiratory system and no matter how strenuous or feeble the inspiratory muscle effort is. And current data actually indicates that this is the most frequently used mode in intensive care units. In CMV or assist control, mechanical breaths can be either triggered by the ventilator or by the patient. The frequency at which time triggering takes place is determined by the backup rate set up on the ventilator, and this is called time triggering. When the patient triggers a mechanical breath, their spontaneous inspiratory effort is sensed by the machine, usually as a change in either airway pressure or in air flow. When such a change crosses the trigger sensitivity threshold, the ventilator will then deliver a preset tidal volume. On this slide, you see from top to bottom the tracing of the airflow airway pressure tracing, and the tidal volume tracings. These recordings were obtained in a passively ventilated patient in a volume-controlled mode. Each breath here is time-triggered. In CMV or assist control, the mechanical breaths are limited by volume and/or flow and are cycled by volume or time. The inspiratory flow shape delivery is usually a square during assist control. Now, when you are in this particular mode, assist control, you have two types of breath. If the patient is passive, it's a VTMB breath. That means a ventilator-triggered mandatory breath. But if the patient is active, then it's a PTMB breath or a patient-triggered mandatory breath. If you are dealing with Hamilton ventilators, then this is where you set up the tidal volume, and this is the inspired volume that you're giving the patient. And on the left-hand side of the screen, you look at, see what the patient is doing. So that is the expired volume. As you can see, they're almost exactly the same. On the right-hand side of the screen, I'm showing you the control panel where you can put in the other parameters such as the respiratory rate, the PEEP, the FiO2. And there are two different types of triggers. You can either choose a flow trigger to make the patient more sensitive, or the ventilator more sensitive to the patient, or a pressure trigger, which is harder for the patient to trigger the ventilator on a pressure trigger. Now, volume control has some benefits. So if I set a volume at 500 today, when I come back tomorrow, it's going to be the same 500 volume. And also the minute volume will be quite stable. But it has some disadvantages. There is patient-ventilator asynchrony. There's invisible volume losses in the circuit. It has no leak compensation. And there's variable peak pressure depending on tidal volume, peak flow, and the patient's inspiratory resistance and breathing efforts. Let's move on to pressure control ventilation now. During pressure preset ventilation, the ventilator applies a predefined target pressure to the endotracheal tube during inspiration, as I've shown here. So here we are setting an inspiratory pressure of 15 centimeters of water. And depending on the compliance of the lung, you will generate a volume. Now that volume has to be regulated to the exact volume that you need. So in this case, if you want to set it up at 500 cc, which is equivalent to 6 cc per kilo for that particular patient's ideal body weight, then this is too much volume. So therefore, you have to scale down the inspiratory pressure to get the desired volume. The resulting tidal volume and inspiratory flow profile varies with the impedance of the respiratory system and with the strength and duration of the patient's inspiratory efforts. Therefore, when the lungs or chest wall becomes stiff, the airway resistance increases, the patient's own inspiratory efforts decline, tidal volume will decrease. This can lead to a dangerous fall in minute ventilation, causing hypoxemia and CO2 retention. On the other hand, the pressure preset modes are no safeguard against ventilator-induced lung injury because the large fluctuations in respiratory impedance or patient effort could result in large tidal volume fluctuations, directly undermining the primary objective of lung protective mechanical ventilation. Let me explain this further. With pressure control, the tidal volume is variable. As I've shown here, there are 3 different types of tidal volume that can be generated with the same inspiratory pressure. And this is dependent on the patient's respiratory resistance and compliance and patient's breathing efforts. So if it's a normal lung and you give a certain amount of inspiratory pressure, you're going to get a resultant tidal volume. But if you have a stiff lung or a non-compliant lung, that same inspiratory pressure will give you a much smaller volume. And if you have, on the other hand, a very compliant lung, then you're going to get a very large tidal volume. The slide here shows the airway opening pressure and flow tracing during pressure-controlled ventilation. Now, pressure control is superior to volume control in that there is a lot of patient-ventilator synchrony. Also, there is leak compensation. The ventilator responds with increased inspiratory flow and thus can compensate even for a moderate leak. Moving on to SIMV, or synchronized intermittent mandatory ventilation. Now, SIMV is similar to assist control, in which mandatory breaths are triggered by the patient. In contrast to assist control, SIMV, the patient is allowed to breathe spontaneously between those mandatory breaths. SIMV is a means of ventilator support in which a preset number of positive pressure mandatory breaths are delivered while the patient breathes spontaneously between these breaths. The mandatory breaths can be in the form of a preset volume, it's called volume SIMV, or a preset pressure SIMV. In addition, the patient is free to breathe spontaneously between the machine breaths, and these spontaneous breaths can be augmented with pressure support ventilation. Unless the patient fails to breathe spontaneously, machine breaths are delivered only after the ventilator has recognized the patient's effort. That is, the ventilator and respiratory muscle activities are synchronized. Now, in an SIMV mode, there are 3 types of breaths that can be generated. If the patient is completely passive, then all the breaths will be ventilator-triggered mandatory breaths. If the patient is active, but the IMV rate is fast, then they will have a combination of VTMB and PTMB breaths. But if the IMV rate is set slower, then the patient will have a time to have a spontaneous breathing, which could be augmented with some pressure support. In the next 2 slides, I will show you how to set this up. So here you have a volume SIMV, so you're setting a tidal volume, and for the patient's own breaths, you can supplement it with some pressure support. Similarly, in pressure SIMV, you set the inspiratory pressure, and to help with the patient's spontaneous breaths, you can add pressure support. These 2 slides are examples of SIMV mode with a slow set rate in which the patient can have their own spontaneous breathing as shown in the red dots, and the yellow dot is showing a patient-triggered mandatory breath. Now, when the SIMV mode is set with a very high rate, then the interval is too short for even one patient's spontaneous breath. So you see here, there are no patient spontaneous breath. So the blue dot is showing VTMB, and the yellow dots are showing PTMBs. Moving on to how do we set up the respiratory rate? Now, the respiratory rate has to reflect what's going on with the patient. So if the patient is having metabolic acidosis, they will need a faster respiratory rate. If they have very tight asthma or COPD, then you want to give them a much lower respiratory rate because that will help with giving the patient more E time, expiratory time. We always start off with 100% FiO2, and then we turn the FiO2 down till we are at non-toxic FiO2, which is 55% or less, keeping the patient's PaO2 greater than above 60. Let's now move into what is PEEP. PEEP is positive end-expiratory pressure, and it is the baseline pressure above which inspiratory pressure is applied intermittently. PEEP is adjustable in all ventilators. PEEP is generated by the interaction between the expiratory gas flow and the resistance imposed by the expiratory valve of a ventilator. PEEP alone is therapeutic as it can increase the FRC, improve alveolar gas exchange, keep the lung units open, and even improve the lungs' compliance. A moderate level of PEEP, 3 to 5 centimeters of water, is generally recommended and may be beneficial for all intubated and ventilated patients. A high PEEP may be clinically necessary for patients with restricted lung diseases, such as ARDS. Avoid the use of zero PEEP, although it is possible. PEEP is usually constant in all ventilation modes. An exception is when you use biphasic modes, where PEEP can alternate automatically between 2 set levels. This slide is going to go over the pressure volume loop, or the respiratory system compliance curve, that measures the static characteristics of a respiratory system. Classically, the curve is measured at 0 PEEP, forming a sigmoid shape because of lung recruitment at low pressure volume and hyperinflation at high pressure volume. In other words, at low pressure volume, there is the lower inflection point, or LIP, created by alveolar opening pressure. Below the LIP, there is little volume change on the y-axis. However, after the LIP pressure investment, the volume rises. The upper inflection point, or UIP, reveals the moment when increased airway pressure no longer raises the volume on the y-axis. The UIP is felt to mark the moment when alveolar overdistension occurs. So you don't want to be below lower inflection point because that's where atelectasis happens. You don't want to be too overdistended above the UIP. That's where barotrauma and volutrauma happens. So the best and the safe ventilation areas are between the LIP and the UIP. Usually the PEEP is set about 2 centimeters above the lower inflection point. So in a normal patient, we usually set the PEEP up at 5 and go to 8. If it's a patient with ARDS, you can go up to 12, but some of these patients may need a higher PEEP levels, and you can base that on your pressure volume loop, or you can place an esophageal balloon to calculate transpulmonary PEEP. In an asthma or COPD patient, their lungs are pretty compliant, and so you will need lower levels of PEEP. Now, the I to E ratio is important. So normally, your E time is more than your I time. If you have a patient with ARDS that has severe hypoxemia, then you may want to have more I time to maximize oxygenation. That type of ratio is called inverse ratio ventilation. In an asthma or COPD patient, their problem is not breathing in, it's more breathing out. And because they cannot breathe out adequately, they develop air trapping and dynamic hyperinflation. So your primary goal when you intubate and ventilate somebody with very severe asthma and COPD is to give them low tidal volumes, but give them more expiratory time so they can decompress their lungs. You always must check an ABG after the initial ventilator settings and then repeat it after you make any changes to the ventilator. This is a schema of how the respiratory system mechanics looks like. As you can see, the airway pressure calculation is pretty lengthy and involves a number of factors such as flow, resistance, compliance of the lung, compliance of the chest wall, and PEEP. Alveolar pressure is measured at end inspiration, and that is a static pressure called the plateau pressure. And pleural pressure can be measured if you put in an esophageal balloon. What is peak pressure? Peak airway pressure during mechanical ventilation can be influenced by a number of factors. It is the increased resistance to airflow in the ventilator circuit or endotracheal tube or in the patient's conducting airways that will be reflected in an increased peak inspiratory airway pressure as shown here, PIP. What is plateau pressure? It is measured during an inspiratory pause on the mechanical ventilator. So you go into the tools and you dial in an end inspiratory pause. And that calculates the static pressure or the plateau pressure. And in an ARDS patient, you want that plateau pressure to be less than 30 centimeters of water. Anything above that increases your risk of barotrauma and volutrauma for that patient and increased mortality. So if the pressure alarm is going off, you need to know whether it is a high peak pressure causing the problem or is it a high plateau pressure, because they mean different things. The high peak pressure is usually an airway issue. For example, if there's a bronchospasm or retained secretions or a mucus plug or an endotracheal tip occlusion. And high plateau pressures is usually a compliance issue, a pneumothorax or pulmonary edema or ARDS or pneumonia. So understanding the difference between peak pressure and plateau pressure will help you diagnose what may be wrong with your patient. The respiratory therapist will also set up some alarm parameters to alert them if something is going beyond their set parameters. So they will set alarm limits for the pressure, for expired minute volume, for respiratory rate, and for tidal volume. So please look for these alarm limits in the control panel. Now, finally, we're going to talk about the ventilator strategies for COVID-19 patients. When do we intubate them? What are the ventilator strategies? And some additional insights. Now, these are the hypothesized phases of COVID-19 infection. Now, the time that we get to see them in the pulmonary critical care practice or in the ICU is usually when they're in stage 2, that is the pulmonary phase, where they encounter a patient with shortness of breath and hypoxemia. As you know well, the COVID-19 usually affects, the virus usually affects the endothelium and causes vasoplegia. So there's a high degree of hypoxia due to VQ mismatching that we see in these patients. Our hospital, we've seen over 200 cases of COVID-19, with a fair amount of them arriving in our ICU and needing ventilatory support. We've created a number of guidelines for these patients. Now, when you start to see the patient after 1 week of having COVID-19, it somehow looks like these patients are falling off the cliff. Suddenly, their oxygen requirements go up. Their x-rays look more dramatically changed, and we are needing to escalate their O2 requirements. So the patient that I mentioned to you in the beginning went from 2 liters to 4 liters to 6 liters to 100%. And we could see that her work of breathing was very impressive. And when you start to see that, very great, you know, using accessory muscles, then you want to really pay attention to this patient, because those very strong negative pleural pressures that are generated lead to the worsening of the COVID-19 pulmonary physiology. So COVID-19 patients with respiratory failure do not all present with the typical ARDS features. We have realized that there are 2 separate phenotypes that are being recognized. And a single patient may actually alternate from one phenotype to the other during the course of their illness. It is important to identify the patient's phenotype to guide the ventilation strategy and the adjunctive measures that might be beneficial to each phenotype. So the 2 phenotypes that are talked about are phenotype L and phenotype H. Now the phenotype L is where the lungs have a near normal compliance. Here the problem is dysregulation of pulmonary perfusion causing a VQ mismatch and increased dead space ventilation. There's also pulmonary microthrombi. And L, everything is low in here to make you remember this. So low elastance, but a high compliance, low VQ mismatching, low VQ matching, low recruitability, a limited PEEP response, and a low lung weight. Here, the infiltrates, as you see on the CT, are towards the periphery of the lung. When the patient moves to the H phenotype, it behaves like an ARDS patient, where they have a lower compliance, but they have high elastance and low compliance, high recruitability, high right to left shunting. They are more responsive to higher PEEPs, and they have a high lung weight. So what we are recommending is the steps after you mechanically ventilate these patients. Initially, you don't know, are they the L phenotype or are they the H phenotype? But once you start mechanical ventilation, you may be able to tease them out. So initially, you put the patient either on volume or pressure control ventilation. The most important thing is do not exceed 8 mLs per kg. So set the tidal volumes to be 6 to 8 mLs per kg. Initiate the PEEP at 5 to 8 centimeters of water. Then conduct a pressure volume loop to identify the lower inflection point and also assess for lung recruitability. So once you have done all this, you would figure out if the patient has phenotype L or phenotype H. Now, phenotype L, as I mentioned to you, has a compliance that's near normal. In this case, greater than 40 mLs per centimeter of water. In these patients, you can target tidal volumes of 6 to 8 mLs per kg. High compliance means less risk of VILI, which is ventilator-induced lung injury. Keep the PEEP 8 to 10 centimeters of water or less. For the H phenotype, the compliance is usually less than 40. You would treat these patients like severe ARDS with higher PEEPs, limit the tidal volume to 6 mLs per kg, keep the plateau pressure less than 30 centimeters of water, and the driving pressure less than 15 centimeters of water. Conduct a PV loop to assess the lower inflection point and lung recruitability, and consider an esophageal balloon to calculate optimal PEEP. It is important to assess the ventilator mechanics every 12 hours or if there's a change in clinical status. Look at the compliance, the plateau pressure, the driving pressure, and the mean airway pressure. As patients may switch from the L type to the H type, and changes need to be made accordingly. Obtain an ABG and a chest X-ray at least once a day and as clinically indicated. Assess candidacy for inhaled Flolan or inhaled nitric oxide. Calculate the PF ratio. Consider proning every patient, or particularly if the PF ratio is less than 150. Consider ECMO evaluation for refractory hypoxemia. For the PV tool and lung recruitability video, I have provided a link below that you can refer to. Finally, I'm going to finish off with these two patients. One is the L-type patient. As you can see, the infiltrates here are in the periphery of the lung. And this is the H phenotype patient that had ARDS-like lungs. That's all I have for today. I hope you find this talk to be helpful and useful. Stay safe as you treat your COVID patients. Thank you very much for your time and attention.